Lau. I'm a partner here at Foley & Lardner and chair of the industry teams. I have the pleasure of welcoming you to today's webinar. Our topic today is Accountable Health Communities Opportunity, Jumpstart Your Social Needs Strategy. Before I begin, let me just take you to our agenda slide, and you can take a quick look at our agenda. But let me deal with a few housekeeping matters first. Today's program will run for 1 hour and will apply for 1 general CLE continuing legal education credit. Anyone wishing to receive credit for today's program must enter the code when it's announced. A box to enter the code will appear on your screen for approximately 30 seconds. We'll do that toward the end of the program. Everyone seeking CLE credit must enter the code in the box on the screen at that time. All New York, New Jersey, and Kansas attendees applying for CLE credit must also fill out an attorney affirmation form and write down the course code in the form. The attorney affirmation form and a copy of today's slides can be obtained in the resource list at the bottom of your screen. For New York attorneys, at least for those who have 2 years or more experience, you can get CLE credit, but if you have less than 2 years experience, you are not eligible for CLE credit today. Completed attorney affirmation forms, once you fill them out, should be emailed to Christina Wade. And Christina's email address is cwade, that's C-W-A-D-E, at Foley, Foley.com. CLE certificates will be sent to eligible attendees by email in approximately 8 weeks. If you have questions during our program, they can be submitted at any time by entering them in the Q&A box at the bottom of your screen. It's on the left-hand side of the screen. And we'll try to answer questions depending on the availability of time at the end. If we don't get to all of your questions, one or another of the speakers will be more than happy to directly respond to your questions by email after the program. So with that, let's get started with today's program. So as many of you are probably aware, on January 5th, 2016, the Center for Medicare Medicaid Innovation, CMMI, announced the Accountable Health Communities model. The AHC, and we'll call Accountable Healthcare Communities through this program AHC, the AHC model is a pilot program that will test whether by systematically identifying and addressing the health-related social needs of Medicare and Medicaid patients, the program can effectively advance the triple aim, whether it can reduce total health care expenses, improve health, and improve quality of care. CMMI believes that it may well do so. And why is that? Well, as this slide, well, we will get to the other side. So there's a slide that apparently is not here at the moment, but there's a slide that would show that social science studies have shown that up to 60% of the determinants of health are attributable to social, behavioral, and environmental factors, and that only about 20% of health is attributable to the type of healthcare interventions on which our healthcare system is currently centered. And here's the slide. As health systems re-engineer to provide and assume financial risk for population health, having effective means of addressing health-related social needs becomes an increased, if not critical, particularly if social determinants of health in fact are the principal predictors or are some of the principal predictors of health outcomes of patients. CMMI will test this proposition by awarding up to $157 million in grants over 5 years to up to 44 grantees in amounts of between $1 million and $4.5 million. Applicants may include a diversity of stakeholders. They can include health systems, provider organizations, community resource providers, governmental agencies can apply as well. And grants will be awarded to stakeholders in geographically separate regions and separate markets. The application deadline for the program is March 31st of this year. Some of you may have seen that there was a letter of intent deadline on February 8th, a week or so ago, but that was purely optional, unlike some other CMMI programs where there is a necessity of submitting an LOI in advance. Here you can just apply. It is not a precondition that you have filled out and met the LOI deadline. You can still be a successful applicant if you applied by the March 31st deadline, regardless of whether you submitted an LOI. Now, let me introduce you to our faculty today. So joining us are executives from Health Leads, and this slide tells you a little bit about Health Leads. Health Leads is really the perfect collaboration partner for Foley on today's topic, since Health Leads is the leading national nonprofit organization in this space. Health Leads' mission is to transform the healthcare system into one that addresses all patients' basic resource needs as a standard part of quality healthcare. Health Leads has more than 20 years of experience working with leading healthcare organizations like Kaiser Permanente relatively recently and Health and Hospitals Corporation in New York, helping them to tackle what we call social comorbidities by connecting patients to the community-based social resources they need in order to be healthy. So we're very fortunate today to have with us 3 executives from Health Leads, and the first of which is Rocco Perla. Rocco is the president of Health Leads. He's a former senior official at CMS, where he helped to establish the CMI Accountable Health Communities model, so he's intimately familiar with it. And he will introduce you to that model. And he was one of the founders of CMMI, of the Center for Medicare Innovation. He'll be followed by Leah Thompson. Leah is a principal of Learning Networks at Health Leads. She's responsible for empowering providers to address patients' unmet social needs with tools, with expertise, and coaching. And she's going to discuss the elements of a successful or effective AHC program. And last, but certainly not least, is Zach Goldstein. Zach is a principal of innovation at Health Leads. Zach leads the organization's work around innovation and technology, including the design of Health Leads Reach, which is its technology platform. He'll discuss how healthcare organizations are using this type of health information technology to connect patients with community-based resources to address their unmet social needs. With that, let me turn you over to Rocco Perla. Rocco?
Thanks, Michael, for that introduction and for framing today's session. I want to start by centering the discussion around the work of the CMS Innovation Center, which, as Michael noted, is responsible for launching the Accountable Health Community Model and will manage it over the 5-year period of performance. As many of you know, the Innovation Center has statutory authority through the Affordable Care Act to test new models of care delivery and payment reform that lead to better care, better health, and lower cost, which is often referred to as the triple aim. The ultimate goal is to scale models nationally after this testing period ensues, typically between 3 and 5 years based on the model. But this can only happen if the model demonstrates cost savings or at a minimum is cost neutral. On the next slide, what you have here are just some representative samples of models currently being tested through the center. These models really reflect a large proportion of health reform activity and thought, all the way from accountable care organizations to work that's happening with Medicaid patients and those that are dually eligible who are on both Medicare and Medicaid, who tend to be high cost, high utilizer beneficiaries. Certainly with the ACO work, you can see all the different flavors there, starting with the Pioneer work and then the next generation ACO, which is the latest model. And the focus with that model is really moving from a fee-for-service type of environment to true accountability for patients wherever they are in terms of cost and quality. The primary care transformation work is really central to the work of CMS, and they're testing a number of different multi-payer strategies to integrate programs such as medical homes into primary care that really shift the focus of the care system on patients and families. Of course, bundled payments is getting a lot of attention here because that focus is zeroing in on specific episodes of care and paying for services around that care to include pre- and post-acute services in one bundle. The challenge here is that as innovative as these models are, none of them directly target health-related social needs. And I think part of the excitement around the Accountable Health Community Model is the explicit focus on social needs and the impact that has on all of this work that's happening in the innovation space. So I'm going to briefly summarize what this opportunity is and then discuss why the model is so important and why I believe it's truly a historic announcement and period that we're entering in here led by this model in CMS. So what is the accountable health community model? As Michael mentioned earlier, it's really looking to formally and systematically test whether or not we can close that gap between clinical care and community services and truly get to a greater integration. The best expression of that in terms of outcomes are reduced costs and improved health and quality of care. Again, the triple aim. And the model here focuses on a number of health-related social needs in 5 core areas, and these will be familiar to anyone that sort of worked in the social needs space: housing instability and quality, food insecurity, utility needs, interpersonal violence, and transportation needs. So over this 5-year period, CMS is going to invest $157 million to test this model along 3 different tracks, and each of these tracks features interventions of varying intensity. So track 1, the focus is on increasing beneficiary awareness of available community services, really through information dissemination and referral. Track 2 goes the next level from beyond information dissemination and awareness to actual navigation of patients who are typically high-risk beneficiaries to the services that they need. Track 3 is, without question, the most comprehensive, and in that track, CMS is encouraging partner alignment through a coordinating bridge organization that can really bring all the stakeholders together to ensure that community services are available, and not only available, but responsive to the needs of beneficiaries who need those services. The one thing I like to point out and stress is that this pilot is really testing both a care delivery innovation and a payment model. And this is a standard in every model that's tested through CMS because of the cost neutrality requirement. So new models, even models that are amazing and just demonstrating unprecedented qualities and improvement in care, cannot be scaled if they increase the cost of care. And that's because CMS is really taking a long-term view here and recognizing that there's an element of sustainability. So if we don't have an actual sustainable model on the finance and cost side, then it's really going to be hard to make the case that this should become the way we do business. There are some risks and challenges with this model, and these have been identified particularly by organizations that are familiar and very skilled in this area. The first is a relatively small dollar amount. So implementing and creating the capability and the infrastructure for a social needs program requires resources, and so some of the concern that we've heard is that the dollars here may not be quite what they need to be. There is also the risk of adverse selection. So organizations that may be very interested in entering into this space may actually be on the lower end of the learning curve if they're not that experienced, and that could have a negative impact on the overall evaluation of the program, and that in turn could have an impact on the potential for scalability. So these are some of the risks. They're not uncommon with models. It's quite common, in fact, to throw out a modest amount of funding to see what organizations can do. But we think organizations need to go into this model with their eyes wide open and really understand the challenges and opportunities. So, despite these limitations, many, including CMS leadership, have referred to this as a historic model. And I can tell you, having spent time at CMS, it's typically not the language government officials use to describe models. They're typically more metered in tone, largely because whether or not it's historic will be borne out in sort of the testing and the work and the learning that gets done and takes place. But when we think about why this might actually be considered such an amazing moment in time, I think it's because there's a series of firsts that are kind of embedded and wrapped into the context of this model. This is, in fact, the first attempt to test social needs integration as an explicit part of the healthcare delivery system on a national scale. These 44 awardees will be represented across the country. And as I mentioned earlier, the other models that have been tested, as interesting and as important as they are, really haven't sort of zeroed in on social needs and using that as the centerpiece for the delivery mechanism. The second first is this payment model component, which creates an economic reality around doing this in a sustainable way, and that is just so important. And then lastly, it's really the first attempt to truly redefine what counts as healthcare by the major U.S. payer of healthcare services, in fact, the largest payer of healthcare services in the world. And I think this last piece is really important. This is, we're not just testing a new approach to team-based care or navigation or a new alternative payment scheme. This is really pushing the boundaries of what counts as healthcare by including social needs, which have long been considered, outside of the scope of healthcare. So it's truly a historical pilot. I think one that stands out relative to the many innovations that I worked on while I was at the Innovation Center, and something that so many of us are excited about. But how do we get here? Well, I believe there are two main reasons. First, I'll use some of CMS's own language here from the funding opportunity announcement. This model is based on growing evidence that addressing social comorbidities through effective clinical community links can improve health outcomes and reduce costs. Now, that cost reduction largely comes through reduced utilization of health resources, things like ED admissions or inpatient admissions, as well as the possibility of preventing patients from becoming high utilizers. So if we meet unmet social needs early and up front, then these are individuals who can actually be averted from having to need the healthcare system because their basic needs are met. As Michael pointed out, we know that a small fraction of the modifiable variation in health outcomes actually comes from clinical care. The majority are from other factors on the social, economic, and behavioral continuum. And when I look at this chart and the chart that Michael showed earlier, sometimes I scratch my head because it's simply inconceivable to think that we can move toward a sustainable, value-based payment system that doesn't have a clear strategy to address the 70 or 80% of the modifiable factors of health. That's not sustainable, it's not realistic, and at some level it's not even logical. More importantly, we hear a lot of talk today in healthcare about patient-centered care. And I think it's hard to imagine a truly patient-centered health system that basically ignores the realities of patients who are hungry, or unable to get to a medical appointment or to the pharmacy, or who are homeless. Think about the phrase accountable care organizations. We don't call them accountable clinical care organizations. So we need to really adopt, I think, this broader perspective, and it's something that is acknowledged, I think, in the CMS opportunity here. I think it also serves as a reminder regarding how challenging the model might actually be. If the current healthcare system is engineered around that 20% of clinical care, then we have some significant work to do in terms of increasing capability and infrastructure. Second, we're finally starting to take population health more seriously, I think, in the United States, and beginning to understand the disease burden of patients with unmet social needs. So take these data from a recent study by Mass General Hospital in conjunction with Health Leads, and we see that unmet social needs were associated with nearly twice the rate of depression, 60% higher prevalence of diabetes, almost more than 50% higher prevalence of high cholesterol and hemoglobin A1C, and more than twice the rates of ED utilization and no-shows. So this is the sort of evidence that CMS is referencing when they are making that argument around increased cost savings. And I doubt that this data surprises anyone, but without this data, we can't really understand the path forward or the magnitude of the problem. And I would go as far to say is we're literally flying blind when it comes to social needs data for our patients. There are other findings, in this case from the same researcher that were presented last year, that found that if we address unmet social needs of patients, we can demonstrate clinically meaningful improvements in patients' LDL cholesterol and blood pressure at a level greater than the threshold the FDA sets for a new drug. So that's pretty exciting stuff. So I think this and similar evidence begins to paint a clearer picture that unmet social needs, unmet human needs, are just a fundamental driver of health and cost, and that by addressing them, we can have real impact on achieving health system transformation and those three aims that we're always talking about. So we have this powerful market signal from CMS related to the transformative potential of addressing social needs in a clinical setting. What does it take to do this work well? This is the primary question the 44 CMS awardees are going to spend the next 5 years working on. And I think the challenge here is balancing sort of the relationship around incentives and actual system change. And this case study, I think, from CMS is a perfect example around the limitations of incentives alone. So in 2015, in January, CMS reported CMS actually introduced a new chronic care management fee, and the agency reported that about 35 million beneficiaries were eligible to receive the billable services, but almost a year into the program, the agency had received requests for about 100,000. And when they did studies to understand why this was happening, the challenges that they heard centered around increased FTEs that were needed to actually implement these criteria, new processes and relationships that actually weren't in place yet. And many organizations just simply weren't capable to do this and therefore to bill for this service. Or when they did the return on investment calculation, they realized the investments needed to bill for these services was actually greater than the revenue. So incentives, I think, are necessary but not sufficient in this case. The hard work is really thinking about redesigning a healthcare system that truly puts the patients at the center of that. And to talk a little bit more about some of these key capabilities for success, I will now hand things over to my trusted colleague, Leah Thompson.
Good afternoon, everyone. I am so pleased to have the opportunity to speak with all of you. So I am going to take you through what we believe are 6 important drivers of success for social needs programs that we have garnered from our work over the past 20 years in a variety of settings. And these 6 important drivers also line up really well with the accountable health communities model. But before I go into the details of all 6, I want to hone in on one of them, which we call leadership and change, and which we think in all cases really has to come first. Put simply, you can't start the actual building of the capabilities and infrastructure until you sufficiently tackle leadership and change. And to illustrate this point, I just want to read a brief email from a staff member that we have operating a program in Baltimore. And this is what she said. She said, "A few providers were discussing an adolescent patient yesterday and were concerned about his recent weight loss. They were discussing potential diagnoses and deciding which blood tests to order and metabolic tests to run. Our staff member was listening closely and wondered aloud if he might not have enough food. The provider said, he's never said anything like that, but please ask him if you would like. Turns out the patient recently had to move out of his home and didn't have enough money to buy food most weeks. He wasn't sure how to access any benefit programs, and he was so appreciative that someone finally asked him." So in this example, there had already been the commitment from someone there at the Baltimore site to put a program in place that would, 1, acknowledge that social comorbidities like food and housing needs exist, and 2, surface them. So getting everyone on board in this way and making this kind of a mental shift, I think really takes a lot of time. But I think what we believe is that you need a critical mass of people in your organization that have done this, made this mental shift in order to get started. So with that, what I'm going to do now is actually walk you through the rest of the 6 program elements. And I think, what we would see, first of all, you will see that these line up really nicely with anyone who's familiar with the funding opportunity announcement and the Accountable Health Communities opportunity. And I think what we believe is to start a social needs program, you need an answer to each as a starting point. And I think to reach the scale that's required of the CMS opportunity, you need a pretty robust answer pretty quickly. And so the first element that we would talk to, the first driver we talk to is screening, so patient identification and screening. So yes, there's a tool involved, a screening tool, and we believe that the tool should look a certain way. This is largely defined for you in the CMS specs, but just as important as the tool is how you actually execute on the screening process. So in some ways you can kind of think about screening as, a faucet, and when you open it to let what will be up to 75,000 patients in, you're going to have the right system to absorb all of the patients that will screen positive. So screening is as much about, the people, both in terms of the variety of roles and the number of FTEs, as well as processes and technology that really enable patients to flow through your program well. And I think this comes down to operational detail and rigor and testing to scale up in a balanced way. The next important driver, perhaps not surprisingly, is workforce. So who will support patients to help them address their social needs? So we've seen a variety of successful approaches using different workforces as navigators, whether community health workers, case managers, or lay workforces like the student volunteers that health leads grew up around. But the key here is that there must be a workforce that devotes significant time to addressing social needs. Where we've seen problems is where, this work is layered on top of an already busy staff person's schedule. The third driver is resource directory, and this is another critical component of the CMS model. And it's kind of written all over the funding opportunity announcement. And I think we believe there are several steps here to do this well. The first is what we would call defining your scope. And what that really means is, because again, the broad needs that you will address are defined by CMS, or at least the core needs, but there's still work to be done in terms of thinking through, the breadth of different types of resources that you will connect patients to within those needs, as well as how far you will take your intervention within each, and what the specific mix of resources is. So I think to do this well, your staff needs to know this. So, how far do they go? When do they stop? With what types of resources? And also, patients need to know what to expect. And once you've defined that scope, you can then really create the resource directory. And I think, some key points here is it's about the right set of quality resources, not necessarily quantity. We've actually seen problems with big databases full of lots of resources. And it's the right information for each resource to really be able to make that tailored referral that CMS is focused on. And finally, I think a really important piece that I imagine Zach will speak to shortly is the right maintenance plan for your resource data. So in any given year in our database, for example, we see 40% of community resources change in some way each year. And it's just not going to work to give patients outdated information and expect a successful connection to that resource. So technology will really be critical there. Next is workflow. So if addressing social needs isn't seamlessly integrated into the clinic workflow, it's just not going to stick. And I think we believe this takes bringing real intention and rigor, again, the right people and processes and systems. And every clinic that we've worked for has a different workflow, as they should, and the trick here is really, a detailed analysis of, the clinic's current workflows and then fitting the new pieces of the social needs program as seamlessly as possible into that current workflow. Impact measurement is another really big component of the CMS model. Collecting and analyzing data systematically will enable you to drive program success and refine operations as needed. So an example, if your number of patients screened is trending down, you should be able to look at the data pretty real time and figure out what adjustments you're going to make in your workflow to get that number back up. Or if you're seeing a low rate of success connecting patients with housing, there's, a gap in the community resource landscape, you can again see that signal in the data and work with your partners to explore what to do. And that brings us back to leadership and change. And so again, this is really about finding your champions, the leaders with the respect and influence in their organizations that have already redefined health and care in their minds and are eager to get others in their organizations to do the same. So all of these elements are critical. What you do on each of them will shift over time. And what I'm going to do to just talk this through a little bit more is give you an example of a collaboration that we have had with a FQHC, a community health center in the Boston area, which is the Dimock Center. So the Dimock Center is and has been for as long as we've known them, deeply committed to the work of addressing patients' social needs. They had already done that hard work of redefining the problem and what healthcare could look like, but they were highly and remain highly resource constrained, like many community health centers. So their goals were really twofold. First, to improve the impact of limited resources, which were grant funded. And secondly, to really track the impact of these resources in the social needs program to be able to maintain and expand funding. And so what we worked with them on was really to arm their own workforce, community health workers, with tools and training, including our REACH technology, which Zach will speak to. But equally important was how Dimock addressed the other program elements that I just referred to. And I just want to give you a sense of kind of what this looked like. So first, in terms of screening, it was about really layering this in smartly. And for example, in one clinic, they did it systematically. They had the resources that could absorb, the number of positive screens that came out of that. But elsewhere, they started really small and planned to scale up. In terms of the resource directory, they put a lot of intention into the right mix of resources. So how deep would they go in certain types of resources, again, taking capacity of their staff into account. And in terms of workflows, thinking carefully through a triage process where they could triage in a way that made sense between a lay workforce and a more experienced workforce based on patient complexity. And so, where that got us was to a place where, yes, we're definitely seeing improvements in productivity, and they're now able to measure what was previously either very hard to measure or not measured at all. But perhaps, even more exciting than that, I think, is, the nature of the questions that we're now collaborating with them around. So, how should you track the impact effectively to eventually enable reimbursement? These conversations were already starting before the CMS announcement, and I think our hope and theirs is that now they will be able to go much faster. And so the question is really, what will Medicaid need to see in order to reimburse for community health workers, for example, doing this work? And then also in terms of learning from program metrics to really maximize the impact of the resources invested. One direction we're planning to take this is really hoping to draw comparisons with other organizations, hopefully, some similar organizations, community health centers, but doing so in a data-driven way where we can really tease out, what is going to drive success in these resource-constrained settings? What are the characteristics of the models that will really enable that, the most effective model? So as I've alluded to throughout, both the Dimock example as well as our program elements, technology is a critical enabler on so many levels. And so at this point, what I'd like to do is turn it over to Zach to talk more about how technology can support social needs programs.
Thanks so much, Leah. Hi, everyone. My name is Zach Goldstein. I run the innovation team and technology team here at HealthLeads, and I've been working with health systems and nonprofits to build strong technology for the past 15 years. And, when I look at the AHC model, technology is one of the most important components of your implementation. And the reason for that is because electronic medical records today actually haven't been built to manage patient social needs. And when I look at that compared to the hundreds of thousands of patients that you'll be serving over the course of an AHC grant, it means that, spreadsheets and paper and partially built EHRs to work on this, it's just not going to cut it. Tech is going to be a really critical enabler for your success. And there's 4 key ways that happens. So the first is around reducing data entry. The AHC, as Leah alluded to, involves pretty complex data collection and reporting requirements, not to mention sharing data across a wide variety of clinical sites and community resource organizations. So there's a significant amount of data you'll need to capture from many different sites. And I think technology can play a really essential role here in streamlining and reducing data entry. The second is around scale. So we've talked a few times about how the AHC calls for pretty significant scale, screening 75,000 patients per year over 5 years, and providing tailored referrals to many of those patients. And to achieve that type of scale and avoid time-intensive manual processes, we've got to look for technology. It's going to be essential to achieving that type of high volume. The third is quality improvement. So as we all know, what you measure is what matters. And to highlight our programmatic successes as well as areas that need improvement, we're going to need systematic data collection on our social needs program. Just like we would measure data on height and weight or blood pressure or referrals out to cardiology, it's really critical to be able to have the data around social needs so we can improve quality of our programs. And finally, care coordination. Most health systems have a wide range of population health interventions going on, designed for different disease states or patient demographics. And, when you're looking at social needs for an accountable health community, we have to remember that that's being considered in the broader context of a patient's overall health. And that means there's got to be true integration into the clinical workflow, integrating into the EHR as well for seamless coordination across all of the different care teams. And to me, ultimately, all of this just comes back to the triple aim. It's about creating better care and improved health at a lower cost. And technology can be a critical enabler of achieving those outcomes and tracking our progress and getting to them. So what are those most crucial capabilities, and what do we really need to be looking at within our technology solutions? There's 5 critical elements and capabilities when you think about what is the right social needs technology solution for the AHC. And those are, first, screening. We need to find ways to identify which patients have social needs through a brief questionnaire and track that data. Second, we need to identify what community resources are nearby and provide them to patients. Third is creating the action plan specifically tailored to that patient's social needs. 4, using on-demand reports and analytics to make better treatment decisions for patients. And finally, underlying all of these is the need to store and exchange social needs data. And I'll talk about each of these in just a little bit more detail here. So when I look at screening forms, the biggest challenge here when it comes to the AHC is that question about scale. How are we going to do 75,000 screens per year? You've got so many patients who will be filling out this screening questionnaire. I think it's about an average of 1 patient every 4 minutes filling out a screening. That means, they're getting the screening questionnaire, they're getting a tailored community referral summary for their needs. You'll need a way to both capture all of that data and do it in a way that supports multiple languages, low literacy, and non-English speakers. That can be a big challenge when you're talking about doing this at the scale of tens of thousands of patients per year. Second, we've got the community referral tracking. And as Leah mentioned, when you're referring to community resources, it can be tempting to think, okay, I just need a directory of everything that's out there. Let me get a nice quantity of nearby food pantries and housing organizations and things like that. But the critical question here is not simply what organizations exist, but how is your technology going to, 1, identify which resources are most effective, and 2, keep that data up to date. For us, after many years of trying to fill our database with as many community resources as we can find, we learned that just 1% of our resources created 50% of our successful connections. There was a tiny fraction of organizations doing the lion's share of the successful work with our patients. And so it's so critical for your technology to be able to track those success rates and also know which data is up to date so we can be sending patients to the right community organizations. Third, just as you would do for any other comorbidity in a clinical setting, you'll need to create a true picture of the patient's health. And that means your technology has to evolve to add social needs into the problem list. It's not something that exists in most EHRs today. And, finding a way to both be able to code what social needs a patient has, as well as tracking the intervention you're doing with them, the goals, the next steps, all the different communication touch points with the patient. all of those pieces are critical within their action plan to ultimately be able to understand how a patient's progressing through their various social needs. Fourth is analytics. The AHC requires award recipients to monitor program execution, continuously evaluate how to improve program quality, and if you're looking at track 3, identify the gaps in the community resource landscape. And Leah gave some great examples of this with Dimock. I think, the data and analytics team is going to be a real driving force behind your work, and your technology is going to need to enable that simple real-time generation of custom reports if you want to track all those different pieces of your social needs program. And finally, storing and exchanging data. So the AHC model involves a huge consortium of clinical delivery sites, community organizations, state Medicaid organizations, CMS, the list goes on. And in a complex model like the AHC, coordinating care across all of these different settings is going to be essential. And your technology has to be able to share relevant data securely, both across your clinical delivery sites as well as with your business associates. At HealthLeads, we use a purpose-built platform that we built called HealthLeads Reach to enable all these different elements of a social need program. But you can choose to build your own, buy a solution like Reach, take more of a hybrid approach. The right solution is going to vary by organization, but I think at its most critical, you need your solution to do all of these different pieces. And a great example of this is the Kaiser Community Resource Hub. Kaiser's been a HealthLeads partner for the past few years, and they are a true leading-edge organization when it comes to addressing social needs. Their Southern California region in particular is conducting innovative work to serve patients, and that's led by the region's Chief Operating Officer, Dr. Nirav Shah, and his team. And Dr. Shah came to HealthLeads with 3 big questions that he was asking. He asked, how might we better address the social needs of our top 1% predicted high utilizers? Can we do that in a scalable and cost-effective way? And ultimately, can addressing patient social needs positively impact health outcomes and total cost of care for high utilizers? Those questions are really similar to the accountable health communities model, and I think are really relevant, this example, to what the AHC is trying to do. And so over the past year, we've worked with Dr. Shah and his team to co-design and launch the first social needs call center in the nation, which we call the Community Resource Hub. And it works like this. So we send an email or postcard out to a patient who's identified as a predicted high utilizer. We let them know that we can help address any social needs they might have, like food or heat or housing. The call center team then calls those KP members a week or 2 later and asks about a dozen questions to find out if they have social needs. Case managers at KP can also make a referral directly into the Community Resource Hub if they realize during the course of a clinical visit that a patient might have social needs as well. And for those members who do have a social need, they can enroll in a joint KP HealthLeads care management program where we work to address their food, heat, housing, and other types of social needs, and ultimately close the loop with other providers to let them know about how the members' social needs are progressing. And for us, robust technology is a critical part of every step of this process. So in this example with Kaiser, we're screening about 10,000 KP members per year, working on calling a pretty high volume, lower than what the AHC sees, but still a pretty significant volume of patients that we're working with. And technology plays a really critical role in streamlining that process. It eliminates double data entry by pulling in data from the EMRs, so we don't have to, re-enter patient demographics or information that Kaiser already knows. It helps us understand things like what times of day are better to call, or what needs are most common, what resources are more effective, and how do we better target our intervention. And it helps us stay connected to the broader picture of what's happening in the patient's care plan. So, with any of these high utilizers, there's multiple providers working with the patient, and the technology really helps us avoid embarrassing moments like calling someone who might be currently hospitalized, or, it enables us to really coordinate well with those providers. And most importantly, at the end of the day, by integrating this social needs data into the electronic health records, the analytics and evaluation teams that we have can regularly review the outcomes data, That enables us to highlight key learnings, improve quality, and ultimately see the full results of addressing patient social needs. So as you think about your AHC model, be sure to look at how technology can help you achieve scale and create a high-quality, cost-effective program. I think it's such a critical part of what we're doing and a piece you really need to consider in your implementation plan. And with that, I'm going to hand it back to Michael Blau to share some closing remarks.
Thank you very much. So this is the time for those of you who want CLE credit to take down the CLE code. So the code for today's program is RFI5K. I'll say that again, RFI5K. R as in Ralph, F as in Francis, I as in Isaac, the number 5, and K as in Kate. I'll give everyone a moment to write that down or put it in their affirmation. Okay, hopefully everyone has the code. And so there are a number of questions that are in the queue, so let's take questions. The first one here is a question from Concilium Partners. Can PACE and dual eligible plans apply for the AHC demonstration program? So I think I've got a viewpoint on that, but Rocco, do you know for sure the answer to the question?
Yeah, thanks, Michael. I think referring back to the FOA, organizations that are receiving funding from Medicare and or Medicaid for other programs except for Medicare Advantage plans and PACE organizations are eligible to apply as long as they meet the requirements in the FOA.
Yeah. So bottom line, it sounds like dual eligibles would be able to apply, but PACE programs generally not.
Correct.
The next question is, let's see. I'm curious about whether you're wrapping health, wellness, and fitness trainers, coaches into, I'm having trouble seeing the question here. If I can get it better centered on my screen. Into the continuum of community resources. So fitness trainers, coaches, whether that's being wrapped into the continuum of community resources. ACE, the American Council on Exercise, a certifying agency, has an advocacy center that's seeking to promote this. So what are you seeing out there in terms of community resources and whether exercise, fitness, and trainers and coaches are being included?
This is Zach from Health Leads. I think, one of the pieces that's really critical when you're thinking about a social needs program is defining the overall, what we would call scope of services or different types of social needs that you're addressing, and how your social needs program integrates with other programs that are happening within the health system. So we do see, some of our locations integrating health and wellness programs is a critical part of what they do. They prioritize that as one key piece, and we'll find those community resources in the directory that we're building in those sites. In other locations, and I think with the accountable health communities model, it's not a formally included, I believe, in the scope that the AHC is putting forward. But that doesn't necessarily mean that a provider couldn't include that in their program and think about broader ways to address the patient's social needs or how they define social needs. So ultimately, I think this is about how broad of a scope are you looking to achieve in your program, and how do you tie the work that you're doing on things like food and heat and housing to health and wellness programs or diabetic care management programs or the wide variety of other types of programs that already exist and are an important part of the continuum of resources.
Thank you for that response. So I see that there's one or two questions about CLE code number again. Let me read it one more time. It's RFI, the number 5K, RFI 5K. The next question is, how frequently do you recommend screening of patient population? So if you can talk about how you embed screening and how frequently you would foresee screening occurring, both under the AHC program, but also what you've learned from Health Leads.
Sure, I can take that one. So I think that the way we generally think about screening, we start with a pretty practical lens on it. So I think we look at a few things. So first of all, when we start a screening program, we look at the existing processes within the clinic, and we try to layer it in as seamlessly to those. So depending on what existing screening protocols are, we might try to follow suit, at least in the beginning of as you're getting ramped up. I think the other thing that is really important to think about that I alluded to a little bit as I spoke was it really depends on the capacity of your workforce. So when you screen, you're kind of turning that faucet on, and as patients screen positive, you have to, have the intervention on the back end and all of the things that get patients to that intervention. And so I think it also partially depends on, the capacity you have to in place to deal with the screens. And so we would kind of look at the lens of what do those two things look like to start, and then build to more to make it more and more systematic and perhaps do it more frequently. I can tell you that often, our starting point, for example, is to add screening in for routine physicals. So when patients come in, but we've seen it happen in a number of other ways. Zach, I don't know if you would add anything to that.
That was great. Thanks, Leah.
Thank you,
Okay.
Leah. So the next question is a little technical, but I think it's trying to get at an episode care question, which is the AHC an extension of the CMS CCTP model? And does it have a periodicity? Are patients followed for 30, 60, or 90 days? What is the follow-up in order to determine whether patients have accessed resources and the impact of accessing resources?
Michael, this is Rocco. I can take the CCTP part, which is the Community Care Transitions Program, which is an amazing program, by the way, focused heavily on readmissions. The AHC model is not an extension of the CCTP, but certainly the work that's happening within that program, just like so many others that are happening right now, could be leveraged to sort of support the work in this in the social needs area. So it is not an extension of the accountable health community model, but definitely something that could be leveraged and is moving in the right direction, in my opinion.
And Leah or Zach, you want to talk about how patients are followed for how long and how impact is determined?
Sure. So there's a couple of, if you look at the accountable health community's opportunity, as Rocco mentioned earlier, there's actually 3 different tracks within the funding opportunity announcement. And there's a few different interventions that an AHC patient might receive based on whether they're determined to be high risk. And there is a kind of randomized control trial aspect of this as well. So some patients get a control intervention versus some get an intervention and navigation. So the 2 main types of work that you'll see in the AHC, one is just a single, they call it a tailored community referral summary, which is basically at the point of care, the patient would receive a list of, if you screen positive for food, for example, you might get a list of here are the 5 nearby food pantries that could help you. You review that with the case manager there in person, and that's essentially the extent of the interaction. There's no additional follow-up beyond that, and that's kind of the low intervention or the control group. The other patients are getting what CMS is calling the navigation service, and that's really a much more in-depth assessment, planning, and follow-up until the needs are determined to be resolved, or you've worked with that patient and realize it's just not possible to resolve the social needs that they have. There isn't a formal time frame on that of, it only lasts for 30 days or it only lasts for 90 days. But from HealthLead's experience doing this for the past 20 years, we've seen that on average, most patients, this work tends to go about 45 to 60 days to resolve social needs with patients. So I think that's probably a rough ballpark, even though there is no formal requirement within the AHC.
And Zach, there are a couple of technology-related questions here. One goes to pricing, one goes to functionality. So is the type of technology solution that you were discussing, the HealthLeads Reach technology, is that possible to be obtained or to build out within the cost caps, the 15% of total award that is allocated for these purposes?
Right. So it does. The AHC requires a cap of 15% of your budget being put to technology, and generally, yes, the HealthLeads Reach solution fits directly within that. It's a subscription solution that's, the pricing is driven by a variety of factors like the number of users and sites and unique workflows, but we'd be happy to talk more offline about specific situations and how to make that work.
And there's also a question on functionality. Can your platform, the Reach platform, handle randomization of patients to the intervention or control group as required by tracks 1 and 2?
Mm-hmm. So the HealthLeads Reach platform does not have that feature today, but it's one we're actually building right now at the moment, and will definitely be ready by the time that the AHC awardees are notified of their receiving the grant.
Very good. Well, I want to thank all of our speakers. We're coming toward the end of our time. There are no other questions in the queue, at least no others that I see here at the moment. So these were excellent presentations from knowledgeable faculty. We really appreciate their comments. And we're grateful to all of you out there on the line for listening in today. If you'd like to learn more about how your organization can apply for an AHC grant or effectively either implement or supplement a social needs program that you currently have in place, HealthLeads will be conducting a series of 3 workshops that either you or some person who may be the right person in your organization might want to know about and might want to attend. And just to highlight these quickly for you, there's a 2-session program, a workshop on designing a strong social need program and developing a successful funding application for the AHC model that HealthLeads will be conducting next week on Tuesday, the February 23rd, and Thursday, February 25th from 1 to 2:30 Eastern Time. Their second workshop is a 1-session demonstration on selecting your social needs technology platform. That'll be next Friday, February 26th, with a repeat session, if you can't make that one, on March 1st, both of which would occur in that same time frame, 1 to 2:30 p.m. Eastern Time. And then the third workshop is really a series of 6 sessions, which is a deep dive on building a sustainable social needs strategy. And there'll be 6 dates to be announced between March 22nd and May 31st. And if you're interested in those programs, you want to know more about the technology, you want to know more about these workshops, you can access that information through HealthLeads' website. Their website is healthleadsusa.org. Again, healthleadsusa.org. Again, thank you for joining us today. Please remember to complete your online evaluations for this webinar when it pops up on your screen at the end of the program. Your feedback really does help us to be the best we can be, so we appreciate your comments. And we look forward to hosting you at future Foley webinars. So thank you again, and goodbye for now.